So we have 11 participants.
I think that's everyone. We have Tracy from video.
Yeah, but we're doing this, so that only the highlighted, the yellow one is the full screen.
Yeah, that's a good idea, Chris.
I wanted to do that on the website, but I didn't do that.
So
Again, this was all.
check my expenses here.
Chris Peabody and Selwyn and Lori.
I'm just admitting, Lori.
Yeah. Nick, would you be as a guest today, or do you want a motion to appoint you as potential member, or we just start with the guest?
We'll just start with the guest.
Okay. So
Morning, Lori.
Until we get to
Morning.
that decision.
the decision making of the council.
Good morning.
Good morning.
Mitch's screen is frozen, or?
No, I'm here.
It's just the projection to the TV.
The projection to the TV here is slowing down sometimes. Great if you're here.
Just tell Mitch to move very slowly and you won't notice. Maybe that's how he moves anyway, is it?
I
Very
was going to say that.
Mute, please.
Hey, Mitch,
Yes, sir.
do you know how to put more bounce in a waterbed?
No.
You put spring water in it.
Oh.
Just saying.
On that note, it's 10 o'clock. So I would like to call the Grayberry's Health Unit Board meeting to order. And first and foremost, do we want to go around the table for roll call?
Certainly. We can go here in-house, Dr. Era MOH.
Matthew McMurdy, Director of Corporate Services.
Councillor Nick Saunders, Fire Chief for Nawash.
So, Mr. Chair, Councillor Sanders is joining us as a guest today, and there is a potential decision from the council down the road to send a representative to be a member on the board of health. And Councillor Sanders is a fire chief as well.
Excellent. Welcome to the meeting this morning.
Would you like me to do the roll call for the members, Mitch?
Yes, please, Sue.
Mitch
Here.
Al Barfoot,
Here.
Ann Edie. Present. Selwyn Hicks,
Here.
Lori Laporte,
Here.
Paul McLean,
Here.
Brian Milne,
Present.
Brian O'Leary,
Present.
Stu Patterson,
Present.
Chris Peabody,
Present.
and then Tracy Smith from BDO. And Christy, you're on there too.
Good.
That's everyone.
Thank you. Are there any amendments to the agenda this morning? Okay, I need a mover and seconder for the approval of the agenda. Sue. I can only see Sue and
So
Brian.
moved, Buck.
I will second that.
Seconded by Buck. Okay. Any further discussions on the agenda? Hearing none. All those in favor? Any opposed? This time I'd ask anybody to disclose a pecuniary interest, either now or for the on the agenda? Hearing none, the adoption of the minutes for Friday, May the 22nd. Mover and seconder.
O'Leary.
I'll move that.
O'Leary and Millen. Are there any errors, omissions, or discussions from those minutes? Hearing none. Anyone opposed to the minutes? Those are accepted. Thank you. Okay, Tracy here from BDO. Tracy Smith, welcome. Tracy's going to present the 2019 audited financial statements. The floor is yours, Tracy.
Thank you. Like to thank the board for inviting me here this morning to the virtual meeting. I believe you have two documents in your package. There's one with a picture, and that's the required communication to the board. The second is a blue report, which is a graphical report that highlights some key financial indicators. Are we going to be able to get those on the screen, or?
Yes, we can.
Which one did you want?
I'm going to start with the one with the picture.
Sorry?
The one with the picture.
Okay.
Can I remind everybody just to put their speakers on mute, please?
Microphone.
Okay, so I am going to start with the one with the picture. This is the required communication to the board. At the end, since we're virtual, I will stop just periodically to answer questions. If we could just go to the summary page. As your auditor, we have the responsibility to communicate with those charged with governance, which is the board on an annual basis. So this report contains all the required communication under auditing standards. The report is very similar to last year, as the content is prescribed by auditing standards. So therefore, we have specific things that we have to communicate every year. So again, it does look the same. The status of the audit, the draft financial statements need to be approved by the board before they can be released in final. And then we have to obtain a signed management letter, and we have to do subsequent event works up to the date of the report. Materiality amounts are material if they would affect the decisions of users relying on the financial statements. So the materiality that we used for the audit is just down a little bit on that page. It was $350,000. So we provide reasonable but not absolute assurance, because we can't audit 100% of your transactions. So we use that materiality to help us focus the audit on higher risk areas. And to use in our statistical sampling. In terms of audit findings, there were no changes to our plan procedures, and no issues were identified in our testing performed. No additional risks were identified during the audit. On the next page, you will see a summary of internal control matters. So if there are we're required to report to you in writing if we find any significant deficiencies in internal control. During the course of the audit, we did not become aware of any weaknesses in the design or the implementation of your internal controls. In terms of independence, we confirm we are independent annually. Unadjusted differences, so we would report to the board if there were items that we found during the audit that could have been adjusted that have not been adjusted. And so we are required to report those to you. Those are in Appendix B. Since the total income effect was only $6,351, you don't have to flip back. We can just keep with the summary. Since the total amounts are not material, we can issue an unqualified clean opinion that the financial statements are not materially misstated. Moving on just to the next page, there management representation letters. So a sample of that is in Appendix C. And then finally, auditing standards require us to communicate on an annual basis a discussion on the responsibilities to prevent and detect fraud. We're not aware of any issues. I can be contacted directly if the board or management has any concerns in that matter. So again, these matters the communication is very similar year to year. I will just stop there briefly if anyone has any questions about that that communication. All right, seeing none, I will move on to Appendix A, which is the financial statements. If we can scroll down a few pages, you'll get to Appendix A, and then you will get to our auditors, our independent auditors report. Just a couple more pages, please. Another page, please. There we are. So then we get to our independent auditors report. So our opinion is our management is responsible for preparing these financial statements. As your auditor, our responsibility is to give an opinion on the financial statements that were prepared by management. So you will see our independent auditors report on page 2 and 3 of these financial statements. The format changed last year, and it is a longer version than it has been in the past, but it is still a clean opinion. Our opinion is in the first paragraph there. It's an audit opinion, so it's the highest level of assurance we can provide as a public accountant. The second paragraph is where you find the actual opinion, and it's, in our opinion, the financial statements presented fairly in all material respects in accordance with Canadian public sector accounting standards. So again, a clean opinion. We didn't have any issues or concerns that came to our attention during the audit. The audit report goes on in the middle there to describe the responsibilities of management and those charged with governance. So those are defined in detail. And then on the next page is the auditor's responsibility, which is detailed in length. Again, it is a clean opinion, so no issues during the audit. So now we get to the exciting part, for me anyway, is the numbers. On the first page there with the numbers, you'll see the statement of financial position. So that's your balance sheet at a point in time on December 31st, 2019. Obviously, the health unit has had more than the rest of your share of changes due to the COVID-19, but this is the historical position at December 31st, 2019. The total assets at that time were $4.2 million, mostly made up of cash, and that fluctuates depending on when your subsidies are received and when the payments are being made. Total liabilities, $13.9 million. That's again mostly made up of your long-term debt. You did repay $553,000 during the year, and that was part of it was renewed last year, and so now all of that debt now comes due in 2033, which sounds like a really long time away, but and those interest rates are 3.3 to 4.82%. The payables are just regular payroll accruals and severances and regular trade payables. The due to province, the $386,000, that has been agreed to the settlement form. So we have gone through the final base settlement form with Christie, and we have all that reconciled, and it does agree to these financial statements. We always want to try to make sure that it agrees, so that you don't have any questions from when that gets sent in. The deferred revenue part there that's described in note 5, the $121,982. So that will be for programs that go, that extend to March 2020. And so you'll still have some funds that were available to be spent from January to March. We come down to the net financial debt. So 9.7 is your net financial debt. So that represents your borrowing that you borrow to build the building. So that will decrease as you pay off the debt. And that's matched with the tangible capital assets down below, which is the historic cost of the capital assets less amortization. So then you come down to your accumulated surplus, which is your equity. So essentially that's your capital reserve fund. So your organization doesn't really have the ability to build up reserves for the future because it's not, you're funded by the ministry. You do have a little bit of capital reserve fund, $1.4 million, which basically is generated from the interest and the rent from the MOE. So we can look at that in a little bit more detail in a minute. I'll just move on to the next one, the statement of operations and accumulated surplus. So your transactions for the year. Total revenues were 14.7. The revenues include all your external revenues, both operating and capital. The Ministry of Health, to 10.4 million, was made up of 8.3 million, which was cost shared 75-25, and 2.1, which was fully funded. There was a cost you did overspend during the current year in 2019 by about exactly $130,000, which normally would be funded and covered by the counties. However, that $130,000 was funded during 2019 from an accumulated environmental program surplus that you had available. So next year you will be going to a 70-30% split, I believe, with the province and the counties. So if you do overspend at that time, there is no surplus left. So any overspending in 2020 will have to be funded directly from the counties. So the total expenses were 14.8, but that includes 898,000 in amortization. So without the amortization, your actual expenses are 13.9. When you compare that to the budget of 14.2, it does look like you actually were underspent with your expenses. However, in those budget numbers, you did have a program for the Ontario Seniors Dental Program, which was about $450,000 in the budget that you weren't able to spend. So even though the expenses in total look like they're lower, you were overspent by the $130,000. It's hard to see. You don't actually see that $130,000 in any of these reports. The annual surplus or annual deficit of the $92,000, that's before your actual capital purchases and your debt. We do see the 130 in the graphical report, so I'll show you that in a minute. The annual surplus, it is negative, again, because there's no mechanism for you to raise funds to cover the amortization. You don't get funding on capital. You don't typically get funding on any capital projects and you don't have any room to raise money for future costs. So currently the only way is through your MTO rent and interest. The prior year surplus of 876,000, that looks like a really large surplus the year before. But the reason that there's such a big difference is because the year before you did happen to get funding, one-time funding for the roof and the generator. So there was $672,000 in one-time funding that showed up in the revenue, and then the capital's on the next page. So that's the difference between why you had a surplus and an annual surplus showing on this financial statement in 2018, whereas you have a deficit in 2019. So if we go to the next page, we take that deficit, the 92,000 deficit, and we deduct the amortization or add back the amortization, deduct the actual capital purchases. So in the prior year there, you'll see that you had $804,000 in tangible capital asset purchases, whereas in the current year, it was only 201. So when you come down to your decrease in net debt, 18 and 19 are more comparable. And then, so from that debt, that decrease in net debt, that's essentially the principal payments that you have that you're paying, and then the leftover rent that you have generated from the MTO. So that is a really quick summary of the actual financial statements. Before we flip to the blue report, I will just stop and ask if there's any questions at this point, since these are the draft financial statements that do have to be approved by the board. Any questions? Okay, there might be a few more questions once we have a look at the blue report. So if I could get you to flip over to the other, yep, that's perfect. All right, so again, the blue report is just the same numbers that you find in your audited statements, but presented in a little different way, and just meant to highlight certain things within the audited statements. You'll see where you are today looks at the financial indicators on your balance sheet, looks at your cash position over the 5 years, looks at your long-term debt position. It started back in 2015 at 12.4, so it's down to 10.4. You're slowly paying off the debt, your principal and interest payments on that debt. And so I just want to stop here for a minute. So under your funding, your mandatory funding, you do have an occupancy budget that covers the principal and the principal and interest repayment. Can we stay on the rate? Yep, on the principal and the interest payments. So back in I guess for the last back in 15, 16, and 17. The funding in that occupancy line wasn't quite enough. It almost was enough to cover the principal and interest. Now the funding is actually a little bit more than your principal and interest repayments, because the interest payments are going down now that you're paying off some of the debt. So that little bit of extra amount that you get on the funding on the occupancy line, that does go into your capital surplus. So we'll see that in a minute on the last page when we talk about the capital reserve fund. Again, the net debt position that decreases as your capital or as you pay down your debt. And if we could just scroll down here to the accumulated surplus. So your accumulated surplus is made up of your capital assets that you got invested in the building and your other computers and furniture and equipment. Here is where you see basically your capital reserve. So your capital reserve is that 1,478,000 number. So that's really the only reserve that you do have. When you come down to the environmental program, you'll see that you had a surplus of 136,342 the year before. That is down to 10,196. So this is where you use the 130,000 in the current year to pay for the extra expenses that you had during the year. So you see you only have $10,000 left. So again, if you are overspent in 2020, then there's no surplus to use. So you'll any shortfall will have to be funded from the counties. You do have a little bit of surpluses here in communities in action and some other programs. But those are specific to those particular programs. Just moving on a little bit in this year-end report, if we could scroll to the next page, please. So again, this is your mandatory program, the 75-25 split. So just the costs that are split between the two programs. And if you scroll down to the bottom, you got 11 million in revenue, and your expenses, to get them to balance to 11 million, you had to use $130,000 there from your environmental surplus. Moving on, this is just a 5-year comparison of those mandatory expenses. We'll just flip through most of this pretty quick. I know you have a long meeting today, so I'll try to and then just looking at a graphical look at the expenses. And then this is all of the programs. So where you've gone and the salaries, how they've matched. And I just want to go here to the last page that has the capital reserve. Okay, so here is the capital reserve. You do have a balance of 1,478,294. So as I said earlier, you do have a little bit of extra in the funding envelope of your mandatory program that funds the principal and interest. So if you see back there in 15, 16, 17, that was the $1,070,000, the $1,080,000. That was the maximum that you could get funded for your occupancy line, which is your rent or your principal repayments. So here in 19, our principal repayments were and interest were $1,034,000. So we did have a little bit of extra, $61,000 that goes into the capital reserve fund. So you'll see the 61,814 there, adding to your capital reserve fund, along with the rent, the 123,677 from MOE, your interest of 24,000. You did pay a little bit of capital expenses that weren't covered under the mandatory programs. So you had an increase of 202,755 in your capital reserve, added to the beginning of the 1.2 means that you have 1.4 in the capital reserve. Okay. So again, those are just some of the financial highlights. I can hear crickets out there. So does anybody actually have any questions?
Any questions from anyone from the board?
Just crickets?
Crickets, yeah. My neighbor is actually out cutting his lawn right now too, so. So can I get a mover and seconder for the, to approve the 2019 audited financial statements by BDO Tracy Smith? So if I could get a mover and seconder to get it on the floor, if there's any other discussions.
Lori.
Laporte, seconded by
Buck here, I'll second it.
Buck. Are there any further discussions? Tracy, just a question for you. So for 2020, will you be doing virtual inspections of the health unit's books? And if so, do we need to draft a policy to make that happen?
Well, it depends on where we are, what the situation is at that time. So we've done the 2019 audit. So the 2020 audit wouldn't occur until about February of 2021. So that's the only time that we would come back and look at the book. So that's a fair time out. So
we have some time. So
yeah.
Okay. Any other questions or comments for Lori? Or sorry, for Tracy? I see Lori on my screen now, so. Okay, hearing none. Are there anyone opposed to the financial statements as presented? Hearing none, those are approved. Thank you, Tracy, for all your work.
Thank you, and I'd like to thank Matt and Christy for helping us finish up the audit during this interesting time of virtual working from home. So thank you again, and thanks for having me.
Thank you, Tracy, for your work on this. Thank you.
Okay, moving on to February correspondence and news releases. So is Drew here this morning?
So, Mr. Chair, we decided to send it like last time for time efficiency. And to have, if you have any questions about it, there are 7 correspondence, one of them to be endorsed and the rest to be received. And similar with the news reports, all of them under correspondence and news release. If there are any questions, I'll be more than happy to try to address them.
Okay, so we will approve that as a package then. So can I get a mover and seconder to get it on the table for discussion?
I'll move it. It's Sue.
Moved by Sue.
Ann, seconder.
Seconded by Ann. Are there any discussions on any of that correspondence?
I was just wondering, Mr. Chair, about that basic income one, and did anybody else think anything about that one? Or, I mean, it was just for information, but I thought it was kind of an interesting concept at this time. I've never seen it before brought forth.
Mr. Chair, if I can provide information on it.
Please.
So basic income is an initiative that was tried different times in the recent history. In Canada and Manitoba in the 70s, there was an initiative to basically provide income to people who cannot work or are not able to work, and to see the outcome. It was evaluated at the time, and the data analysis of it wasn't sufficient. 2 years ago, whether it's academia or public health, went and looked at that data and actually found success in it. And when you adjust to certain variables, people who used it mostly were women who had delivered a baby. At the time, there was no maternity leave. And the second category was people who young men in their teens specifically, who left work and went back to school. And both categories or groups of people to use this system and go back to school or to take care of family is a desirable outcome. So there was a lot of advocacy from public health for the past 3 years to implement it. And it was at some point decided to be implemented in Ontario with the previous government. This has changed recently. Nevertheless, there are other experiences from the world. One of them, the experience in Finland, the result was not that encouraging. People who started the program over 3 years were given income, and at the end of the 3 years, most of them end up exactly where they started. So the data from the experience in Manitoba was very encouraging. The data from Finland is not that encouraging. However, in general, there is essence for this, and public health supports to implement this, especially during COVID. And we hope that the program would continue beyond COVID.
Okay, thank you. No, I just, that's good information.
Other questions or comments?
Mitch, I had just more of a procedural question. The news releases were not included in the package, at least they weren't in mine. So I'm just wondering why, or maybe it was just a technical oversight.
They never have been. They've never been included in the package. They're sent out to the board members as they go out.
You can change it.
We can start adding them if that's beneficial.
We can definitely start adding them, or if you wish, we can add a summary similar to the correspondence summary, the one pager.
Is that the board's wishes? I'm seeing.
I guess it would, from my perspective, at least, it would be a nice review, I suppose. You're listing them there. It would be nice to reference them, I suppose, but that's just my opinion.
Yeah, we can do that.
Certainly. Next meeting, there will be listed all of them, and the summary would reference them.
Thank you.
I would like to recognize the thank you from the city of Owen Sound. That was very nice and thoughtful, so thank you for that. And then I had one other one for Dr. The overdose situation we have going on right now. Is this, in your mind, related to COVID-19, or is this part and parcel of the epidemic we're facing?
The numbers so far are consistent with the numbers from previous year. So it is probably related to the pandemic, or not the pandemic, the outbreak, the opioid crisis. There are theories that, during the COVID outbreak, it's going to be more difficult to provide support to the vulnerable population that uses it, that uses opioids. We have managed to provide communication to reduce risk. We have still managed to provide service in the health unit to people who would require naloxone kits or safe kits to use. So back to the numbers, they're consistent with last year. There has not been a major spike in it.
Okay, thank you. Any other questions or comments? All right. Anyone opposed to accepting these, or the correspondence and news releases? Seeing none, I will take that as approved. Medical Officer of Health update, Dr. Era.
Certainly.
Dr. Air, you're in mute.
Thank you.
Thank you, sir. So I'll start again. So that's the safe reopening Grey Bruce, just an update on the progress so far and the underlying principles. Many of you have already seen some of this material or the slides. There's no presenter conflict of interest. The acknowledgement or the reference mainly is for the Johns Hopkins Medical School. They had put together a plan that is been utilized by many jurisdictions in North America, including our province. I believe many of the steps that we see in the stages are consistent with that academic work from Johns Hopkins. So what does successful reopening means? You would see different understandings from different parts of the community. Many people wanted to keep the number of cases to 0, and other people wanted to reopen their businesses or their activities. The important notes here that all these information in this slide is based on the science of it, and it might be consistent with what's coming from the ministry, but might not be reflected 100%. So we always try to be proactive, preparing businesses and activities and organizations to reopen safely with the best prediction of the science. And so far, the direction from the ministry has been consistent. Of course, the number 5 or 10, it cannot be predicted ahead of time, but there would be prediction of increasing from 5 to something close to 10. So all the information one was presented to the community and different sectors in the community. It was with that important note that this is not dictating the way the reopening is going to be, rather predicting how it's going to happen. And the primary goal during the reopening is minimizing 2 numbers, disease and mortality and death from COVID, and at the same time, equally important, disease mortality from measures to respond to COVID. And the silver bullet we're looking for at some point is to achieve herd immunity, which is 70% of the population to be immune for this disease not to interfere with the way our life used to be, and hopefully soon to be back to what it was. Sorry,
It keeps talking. It keeps doing that.
So this one.
Sorry, Mr. Chair, is the screen that you see says important notes or other slides?
Right now it says primary goals.
Okay, so you see the right one. It's just our screen is frozen here. The disease mortality from measures against COVID, some of it is intuitive. Mental health is usually threatened when people are locked in for a long time. And there is depression, there is suicide. It's as serious, more serious than COVID. The domestic violence is similarly. Heat waves might not be that intuitive. However, there has been enough communication to the public recently to, inform people that continuing lock-in to achieve 0 cases of COVID is going to be on the expense of something that's as serious. Usually, people who would be affected by heat waves are the people who cannot afford air conditioning in their residence. And during COVID, it's very challenging to have cooling centers open for this population. Economic impact is paramount. The economy in Toronto, especially the tourism sector, was affected for at least 8 years to go back to recovery after SARS. So it's important to know that the faster we open safely, the better it's going to be for our area for the long run, knowing that tourism is a major part of the income in this area. So lessons learned from other countries in Asia, some countries had implemented extreme measures, have been able to control. However, the disease is still there, and they need to continue certain level of measures. Otherwise, there will be a resurgence. And for example, in China right now, the screening is for people coming into China, since they had that absolute control over the outbreak. Other experiences, Sweden is one of them, that had a different approach. They decided to say, let's let it burn through, and we can get the herd immunity 70%, and that's going to protect everybody. The data came out of the initial data 3 weeks ago, where at the time there were 4,500 deaths in Sweden versus only 700 in the 3 countries around, Scandinavian countries that compare very well with the social fabric and the economy and the healthcare system. So Norway, Finland, and Denmark had only 700 deaths. Sweden had 4,500. And they only achieved 7% herd immunity, far from the 7-0. So they really gambled on herd immunity through exposure. That probably not a good lesson for to be repeated. Lessons from the US, we continue to see that their approach is regional, is not uniform, and for some or for many reasons, there is less than optimal compliance from the public, and on many levels, we're not in a position to really judge or comment. However, the situation there would affect us if the border is to be opened. Herd immunity, there are different approaches to achieving it. Trying to get the most there. Vaccine is the silver bullet, is what would be practical to go forward. Measles at some point, 70 years ago, 80, 90, was as scary or more scary or scarier than COVID. It claimed many Canadian children's life at the time. And, people forget at this point. You would see physicians going through their training and their entire career not seeing a measles case. And that's hopefully what we're going to find with COVID. Dynamic physical distancing is a nifty idea, really not practical, not for the control of the outbreak, not for the economy, which to say, let's close for 2 months and open for 2 months and repeat until we get the vaccine. It probably will be detrimental to the economy. I'm not an economist in any way, but when I talk to people who are leader in that field, they describe it as a nightmare. Uncontrolled outbreak, that's Sweden's approach. Hammer and dance, it says, that's quoted from John Hopkins. It means let's close it for 6 months. And when we open, it's going to be gone. Again, is there evidence that's going to happen? So far in China, it's not. There is still resurgence here and there. Anytime there is loosening of restrictions or not loosening of restrictions. Anytime the system fails to control 100% people coming into the country or not being monitored that closely. Phase lifting of restriction, the first one, is what we are doing in Ontario, and that's a better practice in public health, dealing with recovery and outbreak. Herd immunity related questions. I heard these questions multiple times. That's why I thought I'll put them here. How much herd immunity is necessary? 70%. How fast will herd immunity build? It's really depending on how the spread of the disease is until we get the vaccine. And in Grey Bruce, we are the victim of our own success because we have very low epidemiology. The herd immunity will reflect it, and it might be as low as 1 or 2% or even lower. How much herd immunity do we have right now? That would be, my estimate is less than 2%. How long will immunity to COVID last? So in general, the coronavirus is have immunity of months to 2-3 years. This virus should not be different. However, because we don't have the follow-up time of 2-3 years, it's a new virus. Nobody can say with 100% certainty, but that does really not mean that there isn't enough evidence to say there will be immunity after there is indication there is, at least for the short term. We have worked with different businesses, subsectors for the past 2 months, even before the reopening word became a word used in the media. We have been planning on documents and communication to the 2 counties, municipalities, businesses. And the speed of reopening, this is one of these documents. We have plenty of them on our website. We have section for reopening and businesses. One example of these documents is this one, and it really reflects that the speed of reopening is depending on different set of variables. The first one, the spread of the virus, the system capacity, and the testing capacity. And each one has many variables that we monitor and we look at continuously. There are 3-phase approach. We are currently in phase 2. However, this document was produced even before the first phase, and this still stands and applies. And you would look at, in phase 2, we looked at sit-down restaurant, religious gathering, hair salons. So our prediction of having the second phase, including these activities, has been successful. And again, we use the same principles that are used by the province or other jurisdictions, and it depends on the science. So, doing the math, 2 + 2 is going to be 4, whether we do it here in Toronto or in, I was going to say in the States, but there could be different maths. And we would expect in the third phase to go back to what's close to normality, as long as we have the many good practices of keeping the 2 meters and possibly the masks, hand washing, sanitizers, dividers in workplace. And there was a question all throughout, why my business? Why that type of business not my business, or why that activity not mine? And the set of variables we look at is the ability to have distance and modify that distance in a workplace, the time required to have interaction in that activity, and the number of people in a specific space. And I mentioned this example before. Golf courses opened first and was expected to open first, and opened first because it's a huge amount of space with small number of people. They don't really contact each other. It's not like a dentist-patient relationship. They just talk from distance, and you can modify many aspects of it. The other side of the spectrum is bars, movie theaters. There are many people in a limited space, and they share many surfaces. And with bars, there's always the disadvantage of having alcohol, where people are not mindful of protecting themselves. Again, another example of how the risk is evaluated to prioritize certain sections. And you would see libraries has low contact intensity, low number of contacts, and medium ability to modify versus places of worship, high density, high contact, and the same modification. Then you do the math and you prioritize them. And we end up predicting many of the steps that the province has implemented, which helped our organizations locally to be ready to hit the ground running when they got the green light. Who decides when and how? It is the province. I get the question, and you might have gotten it, why Dr. Era is not opening faster. It is a provincial decision. We can, the MOH or municipalities don't have authority to override that direction. There is authority to tighten it, to restrict it further. And that's always an option if things go the wrong way. Implementation in 3 phases, and the length of each phase would be between more than 2 weeks. The 2 weeks period is related to the incubation period of the disease. So we evaluate after 3 to 4 weeks, and if everything is okay, we proceed to the next stage. And so far, there is no reason not to go to stage 3 in a couple of weeks from now. Hierarchy of evidence, I've shared this with the group of the mayors from both counties, so all of you probably already have seen it. For the benefit of board members who did not have mayor's position or council position. This is the physical distancing. It's the highest level of control over spread of disease, engineering controls, administrative controls. Then the weakest is PPE. And for some reason, the public keeps pushing why PPEs are not mandated, masks are not mandated in public places. Well, they're strongly recommended and they have achieved the goal. So there is no need to go to mandating them. Plus there is evidence for their efficacy, and no question, we recommend them strongly. But when you see that extreme, everybody need to be wearing them, even you, like, to me, that's when I see it, I just shake my head. I would see a person sitting alone in their car wearing a mask, and they're driving in front of me for half an hour. I'm thinking, like, you're protecting the air conditioner from COVID, nobody else. Anyways, it's a good practice to have the recommendation. We might up it to mandating it if the epidemiology would require stricter measures. A communication will be going out to the media and partners about using of mask and explaining that background of using it. Next steps for reopening, the health unit would have all these things ready to support the reopening. The most important one is the last one, communication. Readiness to test, readiness to the ability to manage contacts and trace contacts is key, is even as important as in the mitigation part of the management of the outbreak. And that brings us to the references. And if you have any questions, Mr. Chair or Council.
Thank you, Dr. Era. Any questions or comments for Dr. Era?
Dr. Era, it's Al Barfoot. Just wondering if you've heard any update towards the vaccine at all?
So the last information and the reference is from CDC Atlanta Center of Disease Control. There are candidate vaccines that reach stage 3. And just to give that short background, vaccines to be approved, they need to be meeting two main tests. Safety and efficacy. And to prove these two features or characteristics of a candidate vaccine, the candidate vaccine would go through 3 stages of trials, clinical trials. The first one to ensure safety, the second one efficacy, and the third one to ensure both, and to ensure it in a larger number of people. So on the first month, in January 2020, there were at least 11 candidate vaccines. Not all of them are going to make it to the finish line, but I have no doubt there will be a vaccine by the end of the year or early 2021. So far, I know of at least one drug that went into the 3rd phase, which means past the 2 phases. This by no means it's going to be a successful vaccine, but there is a lot of investment around the globe into taking financial risk, not scientific risk or safety risk or efficacy risk, scientific risk. And if I may explain, usually the pharmaceutical company or the institution working on a vaccine, whether it's government or private institution, they would invest money into the first stage, and if it's successful, they go into the second stage. Now they're investing in almost everything at the same time, knowing that many of these candidate vaccines are going to fail, and it's going to be financial loss. So So far, there is a good indication that the plan to produce vaccine by the end of the year or early next year is on track. Cautiously optimistic, we will get that goal achieved. Then when we have that approval, there will be about 3 to 6 months to mass produce it for distribution. And that number is based on the same number we see every year with the flu vaccine, where the new vaccine will be produced and within 6 months would be available for public use for mass distribution. Does that answer the question, Mr. Bartlett?
Yes, it does. Thank you.
Anne, I have a question, or not a question, but mainly a comment. So I have I get some emails every couple of days wondering why we're not mandating wearing masks in the, in our municipality, and they'll have examples of counties and other areas that mandate it. So you went through the list there. The best is the physical distancing and down to masks and PPE. So why are some of the areas mandating it? Or is it very restricted? Like I was thinking just in businesses. That's where some of the counties and some of the information I've received, that's just where they mandate it. They don't mandate it anywhere else, just in commercial businesses. What do you think of that option?
So it's like almost every public health intervention, it's multifactorial. One aspect of it is the fact that we have control over the outbreak as good as it gets. Very low number, 0 deaths. If we mandate it, means we're going to increase the number of people compliant with it possibly. How much more increase it's going to be, whether it's 5% or 30%, we're not going to achieve any added benefit in the outcome indicators. The outcome is the number of people infected. They're already as low as it is. That's one aspect of it. The second one is with public health interventions that are restrictive, even minimal restriction to have a mask on one's face, there is fatigue with that intervention, guaranteed. And there is even more guaranteed fatigue about the messaging about it. So if we pull the trigger right now, we mandate it, and in 1 month from now, we have increased risk, increased need for it, real need, because the number of cases have gone up. We might find people getting tired of wearing a mask in public because they've been wearing it for a month. So it's critically important to wait until the last minute to pull the trigger on these interventions, the last minute where that intervention will be effective. You look at other jurisdictions, 3 of them in Ontario health units mandated it for almost different reasons. None of these reasons are here. I believe Windsor, Essex had mandated it, and they have extremely different epidemiology from ours. Guelph has a different situation from us as well, whether it's through compliance. I didn't talk to I spoke to the MOH briefly, but I didn't go into details to see why specifically that was mandated. But here we hear complaints about it. How many complaints? Maybe in Guelph they had way more complaints, and they're doing it just for the sake of complaint. Again, I probably shouldn't speculate here. The final aspect, Mayor Edie, is the legal tests that need to be met to issue an order. The order has a legal component to it, could be challenged. Every order would have in it the right of the person receiving the order to appeal. So if we issue a blanket order to every facility or every business to mandate it, and some of these businesses might appeal and say, I have only 4 customers per day, I have plenty of space, why are you saying I need to do this? If the judge asked me, is this true and the risk is manageable, my answer would be yes, and the order would fail. And with any failure of order, there is a risk of lower respect to the order itself or future orders. So again, we not using it at the right time when it is well needed has extra potential of harm. And again, I probably will be sending, not probably, we are preparing a communication that should go out in the coming few days, if not today, to answer the questions from the public about the different aspects of mask use and orders related to it.
Yes, so thank you. That's just a good refresher. You know, I've read your material on masks, and it's something like just regular discipline. If you aren't reasonable, and people perceive it as not being reasonable, then there will be objections and failure to comply to anything else you might say in the future. Just, yeah, so thank you very much.
Other questions or comments?
It's Sue. Similar to that, I'm also receiving quite a few emails and comments about the masks. So Dr. Era, you said when the epidemiology requires, does that mean when the numbers increase?
Correct. More specifically, yes.
And you won't tell us the numbers, right? How high we have to go before?
It really is like if you see 10 cases one day and all of them related to one family, it truly is one infection, or the risk of spread is not. But if you see 10 cases every day and they're spread out, after a few days you would realize there is a trend going up. So now let's pull the trigger and address it. So it's different scenarios that would reflect that higher risk, and that's why I use the word epidemiology will tell us. We might see it in one day, 20 cases, and they're spread out, and it's evident that they're related to a certain type of business. So we can target that business, and we can evaluate the risk in similar businesses. It is difficult to have one solution that's going to answer every other question. The epidemiology, the data will come and tell us on daily basis, this is the situation. There could be another reason to it. If we find that 30% of the population is very upset, well, doing it to reduce the anxiety is not a bad reason as well. But if we can communicate, educate, reassure the public, that would be the better option. That's least intrusive instead of implementing a measure that will be very useful down the road, but at this point is not as useful.
And just a comment, I find if you wear a mask, people will physically distance. And if they aren't wearing masks, it's like they forgot we're in the middle of a pandemic. They don't, you go into the grocery store or Canadian Tire and no one's following the arrows or separating themselves. But if there is someone wearing a mask, you'll see there's an area that people will stay away from, right? So that's just perception, but that might be another reason to push out there that the education of wearing masks is important. Thank you.
You're right. Anecdotally, I've seen that, and I've, know that people might consider mask as, some cultures have mask as part of their culture, some countries in Asia. So it's easy to just say everybody wears mask because everybody wears mask anyways. Some cultures like Japan, they don't handshake. They keep that distance by definition. So, we look at our social norms and what's best to implement at a certain time. And again, if there's so much anxiety and more complaints are coming after the communication that we're sending, we would consider if this is going to be helpful to reassure people or reduce their anxiety. But at the same time, the legal aspect of it might really not allow us to implement it as most people think it's easy to implement.
Okay.
I just had one more question then, Dr. Harris. So at the last council meeting, in my mayor's report, I did I had looked at some of your material and I did consult you there for it. And, you know, the recommendation from the health unit and Dr. Era is that wearing a mask when you're out grocery shopping or in other places where physical distancing is difficult, or for everybody's safety, just wear a mask. And so is that what you want us to continue like through July with when we have an opportunity to give out that message at council, since, you know, most of us are on TV or recorded, or a lot of us are. Would you still recommend that we continue to do that?
Yes, please. We strongly recommend using masks in public places, especially when the 2 meters cannot be feasible. That's no question. It's like, although I showed the graph where it's the lowest efficacy, but still, because it is useful in that situation where the 2 meters is not honored, because it could be used on a wider scale than anything else, because everybody can put a mask. We strongly recommend using it. And for businesses who wish to have policy to mandate it for their staff and their clients, they can, as always, a reference to the strong recommendation, and they would be able to write those policy. Implementing it from our side as a blanket cover for everybody or mandating it is a different issue, but really does not change the recommendation. Strongly recommend people would wear a mask.
I'll just give somebody else a turn, but I would like to know how other people are finding their businesses as we reopen. The ones I have gone to in Kincardine, I find are doing very well, most of them. So if you've been advising them, Dr. Era, you've done a good job. You know, the patio went out for dinner. They had masks. If you didn't have a mask, our businesses have masks to give out downtown, or most of them. They've found them somewhere. I know Bruce Power was supplying masks to businesses, probably other places in Kincardine as well. So the one restaurant I went to for outdoor patio, which is enclosed, Mitch will know, it's bar down. And there was somebody meeting you, asked if you'd had any symptoms of COVID lately. And we had masks, but the people that were behind us standing, distancing, she made sure that everybody was, if anybody else came along, they were distancing. They didn't have masks, so she had masks for them. And when you went in, you had to wear your mask in, and they had all the areas marked with orange. You could not miss them around your table. And she took you to your table and you sat down. And then she said, and it didn't matter, they had 6 in every grouping. So it was just, there's just 2 of you, there's just 2 of you there at, you know, a table for 6, but they had them together in groups of 6. Another guy came in by himself. He's still sitting by himself. And then there were 5 or 6 came in as a family. They kind of did it like family groupings. It was all very good. And when you finished your meal came like takeout. And so you just opened it up. You got utensils, plastic utensils. Then at the end of the meal, they had a little cart with a little garbage bag in it. And they just asked you to put everything in there from your table and without touching it. And they were, the waitresses were wearing, and the waiters were wearing plastic gloves as well as the face shield. And they didn't come through the meal like they usually do to, you know, if they came, they distanced and said, is everything okay? Is your meal okay? And so it was much different than they kept their distance, but you could still hear them. So, and I've gone into other places too. So I'm really quite pleased that our businesses on the whole are doing a very good job. And she also said she has everybody's phone number recorded for reservations, and she's going to keep them for a while, for a couple of weeks, and then she'll get rid of them in case somebody tests positive in that group. So that's, I don't know whether anybody else has been out to a patio dinner. That was my first. But I felt quite safe. I thought it was very well run. So I have to thank Dr. Era, because I know most of our businesses in our area consulted with the health unit in their opening up, the hair salons, everybody. So I think you've done a great job, and tell your staff, Dr. Era.
Thank you. It's the team's effort here. The team has been doing amazing work on all fronts. Thank you.
Okay, any other comments?
Mr. Chair, it's Brian O'Leary.
Yes, sir.
Dr. R, I'm just wondering, just to share with the rest of the board, I always, before council meeting, just touch base with Dr. R to get some talking points for what I'm going to say at council. I always do a Grey County report. And now I've added a health unit report for each council meeting. And I'm just wondering if everyone is doing that, I'm wondering if Dr. Era, you could just send us something rather short, but, and I know you don't need more work, but I'm just wondering if you send us something in terms of talking points that we could all be sending the same message to our councils and just to have that consistency.
Certainly, that's a great idea, and it's it's not added work; it's the best work there is, because it really reaches way more people from a credible source instead of just sending through other channels, whether the media or other means of communication. So definitely, I will make this a monthly practice.
Great, thank you.
I have a question, Mr. Chair, if I could.
Yep.
Brian Milne here. Dr. Era, you mentioned that it'll take 3 to 6 months once a vaccine is determined to actually manufacture it in sufficient numbers. Does the infrastructure to do that additional vaccine work exist, or is it going to be at the detriment of the regular flu vaccine manufacturing capacity?
It's a good question. Again, the 3 to 6 is based on our experience with the flu vaccine. I suspect it wouldn't be on the detriment of other vaccines or other infrastructure. So much has been invested into response to COVID, and whether I'm trying to think. The flu vaccine, for example, we have a vaccination rate that's not 100%, rather a portion of our population. And if we were successful in convincing everybody in the public to take the flu vaccine, we would have no issue upping the number of doses required to achieve this. And that's on annual basis. So if we turn the same capacity to produce vaccine to one of the most important pandemics that humanity dealt with, I suspect there will be no issue with capacity whatsoever. On annual basis, we're able to do this. We can do it, no effort. But again, this is educated guess. I would say I have high confidence this is doable. But I don't have the means to say I am running that process and I know the ins and outs of it.
Okay, that's good. Thank you.
Other comments?
Yeah, Mitch, I had a comment question.
Yep.
Yes, Dr. Era, thank you very much for your all your presentations and all your, they're very informative. I find them very educational and find it very easy to take your information and convey it on to my council and explain things. That's great communication, especially yesterday's memo on the beach. I found that very good also. I had a question about our numbers and which way they're heading. So I did notice that our numbers compared to the rest, other health units are previously to reopening, we were quite low, but now if you look at the number of cases per 100,000, we're now 10th on the list out of the 34 health units. So I just wondered if you could comment on our number of cases.
Yeah, it is inevitable. We're going to have more cases in the reopening. And the goal, again, from that first slide, the objective is not to keep them to zero, rather to minimize them and minimize the other sources of disease and death, whether heat waves or mental illness. So no question, it's inevitable we're going to see cases rising. If we do our job right, and I mean the collective public health, the public, the healthcare system, the different levels of government, we will not see outbreaks, but it is inevitable to see a number of cases. How come we're moving up the list? For probably many good reasons. We have reopening that's going fast, and as fast as we can, as long as it's safe. So it is still safe. And when you the remarks from Mayor Edie that restaurants are open doing their business, this is really could be generalized to almost everything. And the goal is, if we can go back to a certain level of normality with a manageable number of cases, that is the optimal goal. The goal is not to keep the numbers too close to zero.
Okay, now do we have is the Grey Bruce Health Unit tracking our reproductive rate?
Reproductive doubling time, it is negligible. Doubling time in this case, just because we have 100 cases and now we had, let's say, 10 cases in the past week. So we increased by 10%. If we continue on this rate to reach the 200, the doubling, it's going to take us 10 weeks. So doubling time of 10 weeks is negligible. The scary part was in Italy, for example, doubling time of 4 days. Every 4 days, 3-4 days, you would have, instead of 100 cases, 200 cases. Now we have 10% in 1 week. That's 10% of the doubling time 1 week is, again, it's negligible. This is as good as it gets if we're gonna be moving to open the economy as safe and fast as we can.
Mm-hmm. Okay, thank you.
Other questions? Okay, do I have a mover and seconder to receive Dr. Ayer's report?
Peabody?
Chris? Seconder?
Don't-
Edie? Are there anyone against that motion? Hearing none, I will consider that approved. Corporate Services, Matt.
Thank you, Mr. Chair. So you see the financials as presented in the commentary that was also provided to them. I just wanted to note that we had a small issue with our WSIB in getting it properly out the door in terms of our payments. That little glitch has been solved. Financials are showing a overall surplus year to date so far to the end of March. Not surprising, given that two things are colliding at the same time. There's a number of program expenses that we're experiencing because of COVID-19 that started sort of late February and started a little more earnestly in March. And at the same time, a number of things that we would normally be spending money on, we have a natural surplus that is in the beginning part of a year. So we have those two things colliding. I do think that we also have another part to this is overtime. Doesn't really show up yet in the March statement. We started experiencing it in earnest in late March and definitely into April and then into May. So out of that surplus, there's about $185,000 more of overtime still to come, so that'll eat into that surplus. And I just thought I'd give that overview. Were there other questions in regards to the financial statement?
Moved and seconded to get it on the floor. Moved by Sue.
Yep.
Seconded.
Ellen?
Sue.
So, not specific to the financial, these statements, but are you looking at going out and amending that swap rate of 3.03%? That was mentioned in the audited financials. It'd be nice to get that under 3%.
We have, it's a great question. We have locked ourselves into those swap rates for the next 13 years. We had the swap, one part of the swap that came due a year ago that we renewed for the balance, which at that time was 14 years. The longer term one was the 4% that we had locked in at the outset. So that was very long-term money, and the only way to get to that very good long-term money rates at that time was to use the swap mechanism. If we undo the swap, our interest cost from between, it's like undoing a mortgage. They look at the interest rate differential and say that you owe us the difference on that interest rate differential at this moment in time. So we would end up paying the difference between whatever market rate is now, which is about 1 point lower at this moment in time for the duration of the maturity. So there would be no interest rate savings unless the interest rates actually drop.
Okay, good to know. Thank you.
Other questions or comments for Matt's report? Hearing none. All those in favor, or anyone opposed? Sorry. Hearing none, that is approved. Other, who wants that? Dr. Ayer?
Sorry, I'm looking for the screen. One-time funding for the temporary pandemic pay initiative. That's with Matt as well, please.
So we have, we were given there's two letters. Which one is first? I'm sorry, I don't remember.
One-time funding for the temporary pandemic.
So there's, the province has provided money to us, $85,700, and that is for the $4 per hour increase for specified staff that are essentially frontline workers. So it's very much narrowed down to the nurses and nurses only, irrespective if any other profession had been on the front line for a health unit that was ministerially directed. And now we are in the process of actually going through. They've just given us the guidance this morning on the specifics as to how you determine who was permanently at risk. But they've given us up to $85,700. That's to cover the $4 an hour bump. Also, if you worked enough hours, there's an additional $250 per 30-day period that may also be available to essentially full-time staff. And it's really meant to, as I think of it, as danger pay. Others may think of it slightly different. It is an incentive, but it may also be a bit of danger pay when it deals with amount of exposure or potential exposure to COVID-19. So the ministry has provided this in a formal way to us.
Okay, thank you.
Second item.
Second.
There is also a second item. It is a memorandum, and it's on extraordinary expenses associated with COVID-19. This came a little earlier to us, but it is about a global setting aside of approximately $100 million for us units and it's meant to cover extraordinary COVID-19 expenses that the health unit will incur that are considered both reasonable and COVID-19 related. There'll be more specifics coming our way in terms of how to report, et cetera. What they're really saying is, don't let money be the barrier if you really need to respond to the COVID-19 pandemic. So they're backstopping us, and this is their formal way of saying it. So in this, we understand this money is meant to be whatever we spend over and above our approved budget. That budget is yet to be approved, but I think our expectations are what we submitted to the ministry will ultimately get approved.
On that, Matt, with the call with the Chief Medical Officer of Health last week that Sue and I attended, that allocation funding should be coming next month, is our understanding.
Excellent.
Question, Mr. Chair?
Yes, sir.
Through you to Matt, do you have any estimate of what that extraordinary cost is to this point?
So far, the bulk of our extraordinary costs have shown up as labor. We've got roughly 185,000 in overtime that has been recorded so far. We're still recording a few more bits to that. There's also additional people that we have hired. We also have a natural ebb and flow of people who go on leaves, whether they be maternity or some other leaves, and then us hiring to backfill for that. We have reached out into the labor market, and we have both backfilled and have begun to also the process of adding a few more staff to help us cope with the additional time and effort that needs to go into the COVID-19 response. In terms of total dollars, my estimate at this moment, it is roughly 225,000. That to the end of May, here we are to June. I don't have June's figures yet, but we're roughly about 225. So by the end of June, we could be about 270, 250, 270.
Okay, thank you, Matt. And follow up, if I might, Mr. Chair, to you or Sue, in regards to your phone call with the ministry, did you get a confident feeling that they're going to pay that bill?
Yes.
Whatever it is?
I believe so. I truly believe so.
Maybe I should apply for a job to print money in Queen's Park, should I?
Sue, did you have anything to add? That was definitely my feeling.
Yeah, I felt the same. They said anything over and above the normal budget, they would support. So, yeah, maybe your grandchildren want to, apply, because we're all going to be paying for this for some time. So.
Well, to my knowledge, I haven't got any grandchildren yet, but they may want to, yes. But anyway, I'll be happy if I see the check come from Doug. I'm looking forward to it.
Okay.
Okay, any other questions or comments?
Thanks, Matt.
All right, all those in favor of receiving that report? Sorry, opposed. Sorry about that. So I consider that approved.
Follow along, Mr. Chair.
Oh, sorry. Oh, just one thing I'd like to add from the board, Doctor, if we could just send out another thank you to all our folks, our team members at the health unit, wishing them a happy Canada Day. And again, a thanks for all that they do for us and our public.
Consider it done.
Okay, thank you. Okay, so we are at the part of the agenda to move into closed. I need a mover and seconder to go into closed.
Millen.
Patterson.
Patterson. Going into closed for 3 items: personal matters about an identifiable individual, litigation or potential litigation, and the security of property of the Grey Bruce Health Unit. Anyone opposed to going into closed? Hearing none, we are now in closed. Two and three that were Hello? Can you hear me? Okay, so
Yes, we
item
can hear.
in close were received. Report number 4 is going to be brought out into open for discussion. So, Matt.